I have Dr. Marc Surdyka on the interview today. We're going to be discussing plantar fasciitis. So I really appreciate you coming on the interview right now to discuss more information about plantar fasciitis and what we can do to manage it better. But for those of you who don't know Dr. Marc, he is a physical therapist. He's an adjunct professor at USC, and he hosts or posts a lot of great content on Instagram and on a YouTube channel, and started a new company with a few other physical therapists called E3 Rehab. So go ahead and check them out when you have the time. But thanks for joining us today.
Hey, I appreciate being here. Thank you for having me, Mark.
So first off, what's your background? What's your education level like, and what is your area of expertise?
Yeah, so I am a doctor of physical therapy. I graduated from Emory University. Then I went on to do an orthopedic residency. So I would say that my expertise is just dealing with anything in outpatient orthopedics. So plantar fasciitis being, one of those things that we see regularly.
Yeah, it's a common problem, and it seems to be really difficult for people trying to manage it because it can take so long to recover. I know a lot of the research says that this could be one of the diagnoses that can take potentially a year or longer to fully recover from. So I wanted to get into that a little bit for the people who are dealing with this issue, to hopefully that, by the end of this interview, they'll have a better idea of why they're getting pain and what they can do to get out of that pain. So why don't we just talk about the brief definition of plantar fasciitis? We'll just go from there. And then I'd like to ask you about some of the myths and misconceptions that are out there about plantar fasciitis.
Yeah, so when people are referring to plantar fasciitis, they're referring to pain usually in the region of their heel, at the bottom of the heel, right? So we have a plantar fascia, which is just this dense connective tissue at the bottom of the heel. And, usually people wake up, they have pain on that first step. And so the term itis, and this might go into some of our myths that we talk about, the term itis denotes inflammation and inflammation of the plantar fascia. And we see that that's not necessarily the case. So when we say plantar fasciitis, we're talking about pain on the bottom of the heel, but we can go into a little bit more depth if you'd like.
Yeah, and I was interviewing Dr. Hardin, Jacob Hardin, who's a chiropractor out of Florida. We were discussing tendinitis, and it was a really similar comparison. When you have that itis ending to the word, it means that it's like an active inflammatory process. But when you have plantar fasciitis, it's actually more of a plantar fasciopathy. It's something that it's persisting longer, and it's related to possibly some changes that occur at the actual tissue. And so it may not just be this inflammatory process that's localized. And that's one misconception. So what are some of the other misconceptions? I think that a lot of people think that maybe like stretching in the plantar fasciitis or the plantar fascia is the most important thing to do. Is there any value in that, or is that the most important thing to be doing for this type of an injury?
Yeah, so a lot of what we can, utilize from the research or from our expertise here goes back to that diagnosis, right? So if it's more of a plantar fasciopathy, we treat it similar to perhaps those tendon issues that you and Dr. Jacob Hardin talked about. So, things like ice and anti-inflammatories can help anybody feel good for a short amount of time. But if it's not necessarily an active inflammatory condition, it might not be the long-term solution. Now, in terms of the stretching that you ask, there are some stretches that can be helpful for reducing symptoms. Now, for tendinopathies, for a plantar fasciopathy, it might not be necessarily the thing that you want to do long-term to solve the issue. But as we talked about, people often have pain first thing, they step out of bed, they step on the ground, and they have that sharp pain. Well, there's been some nice research by a researcher by name of D. Giovanni, who shows this plantar fascia stretch that you can do first thing when you wake up in the morning. You hold it 10 times, 10 seconds, so it's about 2 minutes of stretching. Or anytime that you're sitting for a long period of time, so you and me here, we're sitting, we're doing our Zoom discussion here. If we're sitting for a long time and we're expecting when we get up that we're going to have some pain in the heel, you can do some stretching to provide some short-term relief, actually.
So there is validity and it is worth stretching, but it's more for short-term pain relief.
Yeah, as far as we know right now, and it's kind of what the research shows, is that it can be helpful for, up to 12 weeks. And 12 weeks seems like a long time, but as you alluded to, unfortunately, sometimes this plantar heel pain, this plantar fasciopathy can last beyond that. So we have to consider other options as well.
What are some of the other short-term treatment options? So if you're somebody that's having pain and it's been unbearable, you get up in the morning, you're getting that sharp pain, that stabbing in the bottom of your heel, what can you do to try to alleviate some of that pain? Because I know a lot of people do end up resorting to ibuprofen or other anti-inflammatories, or they're taking other pain medications that are prescribed to them, and they're just seeking immediate pain relief just to get through the day. What are some of the other short-term pain relief options?
I think we have a lot of good research as it relates to orthotics, but I think there's also some misinformation as it relates to orthotics. So, you know, sometimes people go out and they buy these orthotics that are $400, $500, $600, these really custom fancy orthotics. And what we see is that that's not necessarily the case. That's not necessarily what you need to have some relief in the foot. So you can be just as well off going and buying an orthotic for $40, $50 compared to the ones that cost $400 or $500. Now, the question becomes, how do I know which orthotic to get? And this can also go into shoe wear, because there's some misconceptions about shoe wear. Probably one of the most important things for the person to do when they're trying on orthotics or trying on shoe wear, especially if they're dealing with this, plantar fasciopathy or this plantar fasciitis, is it comfortable, right? If they're putting on an orthotic or they're sliding it into their shoe and they're walking around and it's making their heel worse or it's not making it any better, that's probably not the right orthotic for them. But if they put it on and they feel immediate relief, despite what that orthotic might look like, then that's a good option. The other option, and what we see in the research a lot, are just little gel inserts, right? And you could probably get a gel insert on Amazon for $10, $20, and that just provides a little bit more cushion, um, for the heel, so that perhaps there's not as much pressure on that area, and so it changes the forces on the foot a little bit. So those are really easy, cheap things that people can do, today.
Yeah, that is, and it's a pretty simple solution. You can just go on Amazon, you can buy some gel inserts, or you can buy just a prefabricated orthotic for $40 and just see if that helps. And it's a low cost option. And then if you need something that is more than that, if that doesn't help you, then maybe you go and get a more expensive custom foot orthotic. I know that we've designed some at my clinic that when we do the custom molds of the foot, you can, for example, if you're having pain on the bottom of the heel, you can elevate the areas around the sore area, so that way that localized tenderness is going to be elevated up, and so you're not going to be compressing that part of your foot onto your shoe and onto the floor. So it's a way to offload the painful area. But sometimes those orthotics can run to up to $300, $400, like you said. And so but if you're looking for just a more cost-effective option, then it looks like there's some research for some of the prefabricated orthotics.
Yeah, and like you said, sometimes just kind of creating that little buffer zone for the heel. Sometimes if you're in a physical therapy clinic, or maybe you look on YouTube, people try these kind of taping techniques. And if that taping technique works, then that might, help you indicate that, oh, maybe the orthotic would, you know, um, help with my heel pain as well.
I like your approach because it's about finding out what's right for the person. I mean, from what I'm hearing, it's like, there are guidelines. There's absolutely research for this, and there's a lot of research on plantar fasciitis, but it's about trying out these different options and finding out what works. And like you said, if you put in an insert and it's actually alleviating some of your pain, then go with that. Go with that option, because the foot's going to react to certain things differently. There's a lot of factors at play.
Yeah, so we have these general guidelines, but like you're saying, we have to find what works for each individual person as well.
Yeah, very highly individualized treatment. What about some of the longer term treatment options? What would you say the research points to as the best, more long term management for plantar fasciitis?
Yeah, so right now, since we're not necessarily considering it an active inflammatory condition, it's often considered to be a load type issue. And what I mean by that is that we can think of it as a teeter-totter or a seesaw, where on one side, perhaps we have load, and on the other side, we have capacity. So capacity is kind of what I'm able to tolerate on a day-to-day basis. I'm not a runner, so I could probably run about a mile. If I run past that mile, then I might have some knee pain, some hip pain, because my capacity does not accommodate the load that I'm putting on my joints and my tissue structures. So for the most part, when we consider this plantar fasciitis, we're considering the capacity of the person and the amount of load that they're putting through it, right? So for a long-term solution, you have to figure out where you're currently at in terms of your capacity and gradually build that up. So the problem with the diagnosis of thinking about it as an inflammatory condition is that people just rest and they don't do much. And in the long term, they actually reduce their capacity, which reduces their ability to tolerate load, meaning that they're not able to walk as far, they're not able to jog as far, they're not able to do some of their daily activities. So that's going to be the foundation, is what can I currently do? Where do I want to get? And then the hard part and kind of the sweet spot is figuring out how to get there. And we can talk about some ways to do that.
I love the analogy of a teeter-totter. So on one end you have capacity and then the load. And so if, for example, if you are a marathon runner, or you want to run a marathon and you get plantar fasciitis, initially you might have to reduce the load that's placed onto the foot. So it requires some active rest, more gentle exercise. You may not be able to run at that time, but then you're going to have to build it back up to reach that capacity. And so the rehab for somebody who's a marathon runner is going to look a lot different than somebody who just wants to walk without pain, because the load and the capacity is going to be different. And so if somebody is a marathon runner, they're going to have to tolerate so much more load to the bottom of the foot to be able to match and withstand that demand that's going to be placed onto the foot.
Right. And we generally see this diagnosis in two distinct populations. So one generally is the runners, and then the other population is generally people who maybe are a little bit less active, right? So as you are alluding to, for the runners, our initial goal probably is to reduce that load, whether it's the running mileage, the running frequency, or the speed. We might have to reduce that initially. Now, that doesn't necessarily mean that they have to reduce all exercise and activity. What they can do, this is something, same thing, you could do this today, is if running 3 times a week is hurting your heel, but 2 times isn't, or 5 miles is, but 4 miles isn't, you reduce that, you replace that extra activity with stuff that doesn't load the plantar fascia as much. So cycling, swimming, some form of cross training, right? Or what we would like to try to do too is add in some kind of resistance training, where we're actually building up the capacity of the calf musculature, the foot, the plantar fascia itself. So, same thing, we're reducing the load. And then we can talk about the other group in a moment here.
Now, is there an optimal amount of reps and sets to do for some of these exercises, or is it also really specific to each person, or is there anything that's more ideal according to the research?
Yeah, so we've seen a couple different studies, and most would recommend that the exercises are actually pretty hard and you do them every other day, meaning that if you're going to start to do heel raises, you probably want to do them at least 3 times a week with a day of rest in between. So let's say Monday, Wednesday, Friday, anywhere between 3 to 5 sets. So if you do this over the course of 12 weeks, you might start with 3 sets and work your way up to 5 sets every Monday, Wednesday, and Friday. With regards to the heel raises, you would try to do them on a towel or on a step. So you get that nice stretch at the bottom of the motion, then you get up nice and high. In terms of difficulty, this is where it's going to be individualized. You want it to be hard enough where you're getting fatigued around 12 repetitions, 8 to 12. So if you're somebody who needs to do it with 2 legs, that's fine. If you're someone who can do it with 1 leg, that's fine. But then there's going to be some people who need some extra weight, where that's where you can put a backpack on, put some weight in a backpack, and do your heel raises there. Now, one of the most important things as it relates to resistance training, running, or even your symptoms is kind of tracking how your symptoms are coming on. Meaning that, if you do some exercise and you have no pain with the exercise, that's great. But if the next day your heel is feeling a lot worse, then that's an indication that you probably had a little bit more load than your capacity. So you probably pushed a little bit too far. On the other hand, if you do some exercise and you have a little bit of discomfort, but the next day your pain isn't any worse, or maybe it's even better, that's a really good sign that you recovered from that exercise. So you have to take a 24-hour response to any movement or exercise. So if it feels okay during the movement, a little bit later, and the next day, then the amount of activity that you did, you're probably in the okay.
I like that approach of taking it 24 hours ahead of time. So you're looking at your symptom response a day later or up to a day later after you work out. And then if you're not having an increase in pain, then you can continue with that exercise or possibly progress it. Do you have any certain measures or markers of when to progress to the next difficulty of an exercise? I know people have a tough time knowing how to go from one exercise to the next exercise, or they don't know when they should progress. And so that becomes an issue because they might overload the foot or they might overstress it, and then they end up going backwards. So they might be doing good for 1 month and then they feel really good. So then they go for a run and then they re-aggravate their foot again. I've seen that multiple times, or somebody's trying to get back to that. So how could they transition back into some of those higher level activities without going backwards and re-aggravating the foot?
Yeah, that's something that I see as well. We kind of call it this boom bust model, right? Where you feel good, maybe you're resting a little bit, not doing as much activity, you don't feel pain, so you go out and go back to doing your previous level of activity, and then all of a sudden you have this flare up, and now you're back down on this curve. So we don't want that to happen. So you're going to have some ups and downs. That's expected. But the goal is we don't want to have these huge ups that lead to these huge downs. So if you're a runner and you're trying to get back into running, you need to do it in a very gradual, graded approach, meaning that you haven't done 5 miles in a month or two, and right now you're only running a mile or two, and that mile or two feels great. Well, make sure that you can tolerate 2.5 miles, I would say at least 2 sessions in a row, right? So if you can do 2 sessions of resistance training or biking in a row and it feels okay, then push a little bit more. But same thing, you're at 2.5 miles now. That doesn't necessarily mean you jump to 5 miles. Now you try 3 miles, right? Does that feel good for a couple sessions in a row? Now try 3.5. The reason being is that if you're normally running 2 miles and you do 2.5 miles, and all of a sudden you have an increase in pain, that's not a huge jump in load, right? So that since it's a small jump in load, most likely if you have an increase in symptoms, it'll resolve much more quickly than if you jump from 2 to 5 and you have this huge spike in load and this huge spike in symptoms. So I guess one of the biggest things is trusting the process, right? And tracking that progress over time, because it can be very difficult without maybe a written approach of seeing that progress, because it's very possible actually to have an increase in function and an increase in activity with the pain staying relatively the same, meaning that you were running 2 miles and you had a 2 out of 10 pain, but you've been on this nice, consistent, graded program, and you're now running 5 miles, pain is still 2 out of 10. And if you don't have this nice log to look back and say, you know what, wow, I've increased 3 miles over the 8 weeks, even though I still have a little bit of that pain, that's a huge improvement. And for the most part, that's what we're looking to do initially, if people can tolerate it, is increasing their function. And as that function increases, that pain should start to decrease as well.
I love the approach of looking at your actual function and measuring how much activity you can actually do. Because if your pain level stays the same, let's say you're having a 4 out of 10 pain at the bottom of the heel, but you were getting that 4 out of 10 pain when walking 1 mile. But now you're outside and you're walking 3 miles or 4 miles, and then you're getting 4 out of 10 pain. But before, you couldn't even do that. That's a significant improvement. So the pain level itself is not the only measure. It's not the only marker of success. It's also how much activity you're able to do, how closer are you to your goal, even though you're having pain. So I like that approach, because when you're rehabbing, it could be very frustrating. It could be almost extremely discouraging to the point where you just want to give up on the process. But like you said, you just have to trust the process, trust the science, and know that if you slowly progress the load to the plantar fascia over time, then it can adapt and get better.
Yeah, and like you said in the beginning, with the prognosis, it can take a long time, right? But that doesn't necessarily mean everyone is going to take a long time. We just have to treat it in such a way that that's the expectation. Now, someone might get better in a month. They might get better in a couple weeks, and that's great. But the expectation is that, hey, let's focus on your function. Let's make sure that you're doing things that are meaningful to you. So if you're not somebody who's really into fitness, that's okay. Maybe work is meaningful to you. Maybe playing with your kids is meaningful to you. Let's make sure that you can do those things, even if they cause a little bit of discomfort, because the expectation is this is probably going to take, several months of working together to try to tackle this issue.
It's great knowing what the expectation is can help prevent some of that disappointment, just because you have an idea of what the timeline should be like. So then if you're ahead of that timeline, then you should feel great about that, and feel like you're doing good and having a successful recovery. I think of it a lot like people trying to lose weight. Sometimes if you get on the scale too often and you look at what your body weight is, it may not change, but your body composition can change. You can have a redistribution of fat where you're not having as much body fat. Maybe you're gaining more muscle, but yet you're the same body weight. So you can still be a lot healthier even though you're the same body weight. You can still have pain in the plantar fascia or in the bottom of your foot, but you can do a lot more and live a better life, be able to go out, with your husband or boyfriend, girlfriend, and go for a walk or a hike. And so those are all things that are extremely important and give somebody motivation to keep going with it.
Yeah, and it gives us a subjective measure and an objective measure. So a subjective measure can kind of be your experience of pain. Let's say first thing in the morning when you step out of bed, and you rate your heel pain as a 4 out of 10 pain. And that's an okay measure, but that might be a better measure to see how you tolerated the previous day of activity like we discussed. So you walked an extra 3 miles, you jogged an extra 4 miles. Is your heel pain that same 4 out of 10 pain? If it is, that's a really good subjective way of saying, I tolerated that increase, level of activity. Kind of a more objective measure is looking at your calendar, asking your significant other, talking to your physical therapist, and seeing, wow, back in January, I was running 1 mile at a 10-minute pace. And now in April, I'm running 5 miles at an 8-minute pace. I still have some pain, but objectively, I'm doing a lot better there. So we can use both of those for slightly different purposes.
Yeah, measuring the objective and the subjective. So if you are, let's say both of those measures are not doing too good and somebody feels like they've plateaued in their progress and they're just not getting better, at what point is it appropriate to go ahead and to go back to the doctor and ask for an injection or a surgery? I mean, are these things that could be used in conjunction with the exercise program, or are we trying to avoid them as much as possible? Do they have a place at all?
From what I've seen as it relates to surgery, I haven't really seen any indications for that as it relates to plantar fasciitis, because once again, the expectation is that it's going to take a long time. And so I haven't seen any outcomes where it says, hey, having that cut is going to have, better long-term outcomes than just going the more conservative route. As it relates to cortisone injections, that's a tricky one. And that's one that's more information is coming out on, because we see in other soft tissues, connective tissues, that it can have a negative effect on that tissue, especially if people are getting multiple injections. In the plantar fascia, the research is mixed. There is some that shows that it can provide some short to medium term relief, and there's more information coming out about that. So I would say that would be a discussion that you would want to have with your physical therapist and your doctor, if some of these other things are not working the way you want, but hopefully at least still knowing the expectation that this is going to be an issue that can take some time.
Yeah, I was reading about there was a 2019 systematic review that was looking at cortisone injections for heel pain, and there were some good outcomes for short-term benefits, but there's other factors at play, because they actually compared it also to a sham injection where they gave a placebo injection, and that was also effective. And so the question is, how much more effective is the cortisone injection than just a placebo injection, and whether or not it's just changing our perception of pain at that area. So it definitely is something to be studied more, I think. And, it's not, I don't think surgery or injections are something to be completely afraid of either. If somebody has to go down that route, I don't want to create fear that they have to go down, to go with those options. But at the same time, if they can prevent doing a surgery when there's really minimal research to support it, especially for something like plantar fasciitis specifically, because it could take such a long time to heal from. So, it seems like a better option is to go with more conservative approach.
Yeah, and that's where you want to make sure that your medical doctor, right, and let's say your doctor of physical therapy are on the same page, or your orthopedic surgeon and your physical therapist are on the same page. Because our recommendations, although our practices are different, right, we're not surgeons, maybe they're not physical therapists, but our recommendations should be similar, kind of guided by that research. So, hopefully that doctor is saying, yeah, do some of these exercises, you can try some of these inserts, and the research on cortisone injections is mixed. So, hopefully you try to find healthcare professionals who are on the same page and communicate that information in a similar manner.
Yeah, and there are really great physical therapists and really great doctors out there. In San Diego, I work part-time for a large hospital some days, and the communication between physical therapist and physician is really good. We have a good messaging system. We're able to task them and send them a note and let them know how a patient is doing, and they're very respectful about our opinions. And then likewise, they'll provide suggestions as well, and we can help manage a patient better that way. So it's ultimately this multidisciplinary approach to helping the patient and figuring out what can help them, and yeah, so they could really just get back onto their feet.
Yeah, absolutely.
Well, what about any pain medication? As far as what is your take on taking prescription pain medications for plantar fasciitis?
So same thing, and the disclaimer that we don't prescribe medication, right? That's not what we do. But we have to think about the purpose and the diagnosis and why people are using it. And if we're not considering plantar fasciitis to be an inflammatory condition, well, then taking anti-inflammatories might not be the long-term solution. Now, obviously, there are cases that potentially you have to take some anti-inflammatories. Maybe you have an important event coming up, you have a wedding coming up, or you get an important meeting where you're going to be on your feet all day. There are times and uses also for anti-inflammatories, but there are side effects if you're taking some of these medications for months, years at a time. So that's another discussion to have with your medical doctor and say, when is it appropriate and what's an appropriate time frame? Because most likely you don't want to be taking these things for months and months on end.
Absolutely. And you can reduce inflammation by eating better. I mean, you can do different lifestyle modifications for that. And it's likely to make a bigger difference for issues that are more inflammatory. So for example, if it's related to severe knee osteoarthritis and you're at the end stages of osteoarthritis and you're getting inflammation, and that could play a bigger role. If you're looking at something like plantar fasciitis, where it's more of a possible adaptive change over time, then maybe taking anti-inflammatory is not going to help specifically with plantar fasciitis. And if you're taking ibuprofen, then again, these are all things to discuss with your doctor as well. But if you're taking it for a long period of time, then there is research to show that there are some negative effects from that. So yeah, this is a topic that I'm passionate about too, because you know that I have a turmeric supplement company, because high potency curcumin, there's a lot of research for it. There's about 30,000 studies and looking at doing a dosage over 500 milligrams of turmeric extract, which is mostly made of curcuminoids. It's a standardized formula of 95% curcuminoids, and it shows to have some similar preliminary effects to ibuprofen and diclofenac, specifically for knee arthritis. But again, it goes back to more of an inflammatory condition. So yeah, we just have to really match the reason why you're doing something with with the modality.
And I use the term load, and I implied physical load, but it doesn't always have to be physical load. So as you alluded to, right, there's a lot of things that can just kind of increase maybe systemic inflammation or increase systemic sensitivity. So, eating better, there is some research for weight loss, if that's appropriate. How's your sleep? How are your general stressors in life? So, those physical things are really important. But if you notice that you had a really bad day, you had a bad night of sleep, maybe you're not eating the best, and that also increases your heel pain, that's just something to consider, right? So just like we take a multidisciplinary approach with, other healthcare professionals, it can be very beneficial as well to take a multifactorial approach and just say, how's my health and lifestyle habits as a whole? And do I notice that, certain things actually influence my pain, whether it's heel pain or something completely different?
Yeah, and some of these conditions, they have correlations to high BMI. So that's the body mass index, and that is calculated based on weight and height. And so it's not always a complete accurate measure, because there could be other factors involved there as well. But there are some correlations between having high BMI and plantar fasciitis. And so it's just, we need to look at, like you said, all these different factors to consider, what is contributing to the pain. And in some cases, sometimes this pain is related to a mismatch between the load and the capacity of that tissue to tolerate the load. But in other cases, you can have some neuropathic pain. Those are more changes in the somatosensory system. So these are poor or maladaptations of your neurological system. That pain is a very complex system, and so even though it has some physical properties to it, there is some that are more physiological properties or qualities to the pain.
And I think it's important, right, that you get the appropriate diagnosis from a healthcare professional, because a lot of people say heel pain is plantar fasciitis no matter what, right? It's kind of like, if you have heel pain, we associate it with plantar fasciitis, but there are other conditions that can have pain in that same region that might not necessarily respond exactly the same way to some of the management strategies that we're discussing today.
Absolutely. There's been a handful of times where somebody's had lumbar radiculopathy, which is having an issue in the lower back and having pain shoot down right into the bottom of the heel. It could be one of the sacral nerve roots, and it could be sending pain right to the heel. And if you clear the lower back, then the heel pain can go away. And if you load up the plantar fascia or stretch it, they're negative for all the different tests for plantar fasciitis. They could walk fine, weight-bearing activities don't bother it, and it was related to the back. That's happened a few times with different referrals that I've had that have been specifically for plantar fasciitis. So yeah, the diagnosis is extremely important. And so it goes to show that it is important to consult with your doctor and physical therapist for the proper treatment plan.
Yeah, absolutely. I couldn't agree more with that.
Great. Well, appreciate your time. Is there a free resource that you'd like to share with the audience today? This could be an ebook, it could be a website article, or any kind of piece of information that you would like people to have.
Yeah, so as you mentioned, E3 Rehab. If you just type in e3rehab.com, I have a great blog that really outlines a lot of this information and kind of gives you some strategies for dealing with this heel pain. We also have 2 YouTube videos on e3rehab.com. So if you want to check those out, and those are free resources, right? So, check those out. And then, yeah, you can find me on Instagram at just type in my name, Marc Surdyka. Ask me a question, happy to answer. Yeah.
Perfect. Well, I appreciate your time today. I'm sure all the listeners got a lot of value from it, and hopefully people have a better idea of how to rehab from plantar fasciitis. So go check out E3 on YouTube and on Instagram, and hopefully we'll maybe have you back on here at sometime in the future.
Awesome. Thanks for having me on, Marc.
All right. Really appreciate your time. Thank you.